So we're going to talk about arthritis, arthritic diseases, different adaptations you guys can do, and some interventions to go along with it. So there's our learning objectives. So there are about 100 different types of arthritic conditions, meaning there's tons of different ways that arthritis, either by disease or what joint it affects or organs it affects or whatever. There's so many different things. You guys can look through a bunch of these different types of arthritic diseases on those different websites, and I encourage you to do so. But I'm just going to go over the more common ones today that you guys will be treating. So there are more, and I encourage you to look them up and be ready for questions about those on your board exams and things. But for us, I'm just going to go over the big ones. You guys feel free to stop me if you have questions, okay? So what is arthritis? Arthritis, it can be inflammatory, it can be infectious, metabolic, or autoimmune. So this is not just your grandpa's aching knees. Okay, there are so many things that arthritis can affect and in different ways. It can also be progressive, meaning it just gets worse. It can be static, meaning it's about what it is and it stays that way. It could be in remission and could be in exacerbation, which means in remission means it is getting better or it's not affecting your life right now. Exacerbation comes in periods and it comes in waves that it could be flared up. It could be hurting right now, but it could be in remission later and not hurting. Okay. Now we're going to talk about what those look like in these different common types of arthritis, but just know that it could be across the board different. Basically, OT in a nutshell with arthritis is we're not going to cure it. You don't cure arthritis, okay? Not for OT. We're going to help improve or prevent decline from function. We're going to reduce pain, hopefully, or help them manage their pain, preserve their joint integrity because arthritis does a lot of wear and tear in their joints, and improve quality of life. Got me? Those are the four big components of OT. We are not curing arthritis. Okay, so the two big ones that I know you guys have heard about before is osteoarthritis and rheumatoid arthritis. I want to now the next several slides is like a continuum. I hate how they do these PowerPoints, but just bear with me. It'll all make sense in a minute. There's a really helpful chart. Okay. So for osteoarthritis, you might also hear it called degenerative joint disease or DJD. This is where the articular cartilage, so the cartilage that is in between your joints and things is keeping things flowing. It wears away. And you get to a point where it could be like bone on bone rubbing, okay? Which is super painful. Super painful. You'll often hear osteoarthritis also called like the wear and tear arthritis. You see a lot of OA in blue collar jobs and in hardworking joints and things like that, back, knees, shoulders, fingers and hands, neck. You can get arthritis in any joint in the body, okay? Any joint, but it is more prevalent in weight bearing joints. Okay. And we're going to continue to talk about this. So wait for a second on your questions, but if I need to slow down, let me know. Rheumatoid arthritis is totally different than osteo. Totally different. This is systemic. It's an autoimmune disorder where your body's literally causing inflammation and attacking itself. So it's causing this huge inflammation and flare up. Okay. This can affect your eyes. It can affect all of your internal organs. It is a really crazy disease. It really is. You have remissions of, or you have periods of remission and you have periods of exacerbation. Again, meaning you'll hear this in lay terms like, oh, it's flared up, or this is, my joints are flared up today. You'll hear people with RA say. Who remembers what one of the biggest contraindications is for RA as far as like modalities go? We talked about it last semester. I made you all put your hand over your heart and raise your hand and swear that you would never do this.
Don't use heat.
Don't use heat. Absolutely. Don't use heat. All right. So this is kind of what a joint looks like in a different way. So your normal joint, you have the bone, you have that fluid cartilage that lines the top of the bone. So you never should have bone on bone in a normal joint. And then you have that synovium, or that pouch that holds that synovial fluid. And then it is encompassed by that joint capsule that holds it all together. Now, that synovium, that's where we're going to focus on for rheumatoid arthritis, and that cartilage is where we're going to focus on for osteo. Does that make sense? Okay, so looking at rheumatoid arthritis, you start to see a little bit of bone erosion, and that comes from this swollen and inflamed synovium, right? So that synovium that's holding in that synovial fluid becomes inflamed and angry and very painful. This results in eroded cartilage and bone erosion. It does a real number on your joints. Like somebody that has RA in their joints it's awful. It really is painful. It more or less just destroys the joint. Now, on the flip side of that, osteoarthritis, this is where that cartilage is thinning. This is that wear and tear. So eventually it just gets closer and closer and closer together until there's bone on bone and it's rubbing against each other. This causes bone spurs, or like spiky ends on the bone, and that's rubbing against each other, and that is super painful. Okay? So wear and tear arthritis is osteoarthritis. Rheumatoid arthritis is more systemic, okay? It's your body like attacking itself more or less. The most common between these two, or between all types of arthritis, is osteoarthritis, okay? Or degenerative joint disease. Again, you may hear it called that. That is the most common. Rheumatoid arthritis is common, but it's not nearly as common as osteoarthritis. Is everybody good so far? If you're not, unmute and tell me you need me to repeat something or explain or slow down, because I can't see your faces on this platform. I can just see right now, I can only see Sydney, and I can see my PowerPoint. Okay.
Slow down just a little bit.
Okay, I will. Anything you need me to repeat? Okay. All right, so this is a really good table. I think this comes directly out of your textbook. I don't remember what page it is on, but it helps you to differentiate between rheumatoid and osteoarthritis, because they can look similar at times, but it's very important to know the difference. Okay. So rheumatoid arthritis, it can begin at any time in life. It could happen, in the very early childhood, and it could happen later in life. And it's pretty scary if it just randomly pops up. Osteoarthritis, on the other side, it begins generally later in life because it's from wear and tear. Like babies are not born with osteoarthritis, but they can with RA. So the speed of onset with RA, it can be very rapid, over weeks or just months. With OA, it's very slow, and it takes years of progression and things like that. It continually gets worse. The joint problems that you see, or the symptoms, are the joint. For RA, they're very painful. They're swollen. They're stiff. And they may still be stiff in osteoarthritis, but that's just kind of the hallmark of RA, is stiffness. Osteoarthritis is their joints ache, or they may be very tender to touch. Like my mom has osteoarthritis in her thumb, and if you like try to touch her thumb or something, like, she freaks out. But you're not going to have a lot of swelling with OA. Okay. So if I ask you where you're going to see the swollen joints, or this thing is called fusiform swelling, I'll show you what it looks like in a minute, but that is RA. Osteoarthritis, you're probably not going to have very much swelling. All right, so the patterns that you see, it's not often, or it's often, but not always. It affects all joints that are in the body. It doesn't matter if they're small, large, or whatever. It doesn't discriminate. It's going to affect whatever joint it wants to, but it's symmetrical. So you'll see it in the same joint on both hands or both wrists or elbows or the balls of the both of their feet, wherever it may be. Like it's going to affect the same joint on both sides. Not always, but very often it does that. Now with OA, the normally you start to see it on one side. An example is like if your left knee starts hurting and it's osteoarthritis, and then you start babying it more, and then you start walking a lot more on your opposite knee. Then you're starting to get symptoms in both knees because you babied one and start putting more wear on the other. Um, so yeah. You see this a lot in people's hands. And again, large weight bearing joints, hips, knees, spine, things like that. But hands, very common as well. Are you guys good so far? Okay. Now, the last little part of this table is the duration of morning stiffness, because anybody with arthritis will tell you about their morning stiffness. So if it lasts longer than an hour, it's RA. It can be very difficult for somebody that has RA to get going in the morning, just because their joints are so stiff. Now with OA, they're still going to be stiff when they wake up, but that should start to go away a little bit after they move. Um, but at the end of the day, when they start getting, sitting on the couch for longer periods of time, that's when the stiffness starts to come back. Okay. So super, super stiff in the morning is RA. OA, you're still stiff in the morning, but usually goes away about an hour or so after you've been moving. And then it comes back later in the day when you start to get a little bit more sedentary. Okay. Now, the presence of symptoms affecting the whole body. It is, you see frequent fatigue and a general sense of being ill with RA. You just don't feel good. Like your body's attacking itself more or less. So you just don't feel good. Okay. It's almost like flu feeling, achy all over, that type of feeling. And then OA is whole symptom bodies are not present. Okay. This is specific to whatever joints that are being affected by OA. You guys got that? I think that table is very helpful in going back and forth between the two because they can look similar at times and they can look, um, they mirror each other. Okay. All right. So some other signs and symptoms. Again, this is just really good for your studying to go back and forth between the two. We've covered these, but these are hallmark symptoms. Okay. This is good for your knowledge assessment today and for your exam. For OA, you see joint pain, joint stiffness, decreased range of motion, some inflammation, but not much. Remember, it's almost not there. Very little. Difficulty in performing daily activities, visible joint changes. I'm going to show you what those look like here in just a second. And then muscle weakness comes along with it too, because they baby that joint or whatever it is for so long, like they literally lose muscle mass. RA, you see these tender, warm, swollen joints, that fusiform swelling, morning stiffness, rheumatoid nodules. Show you what that looks like. And then a fever, fatigue, weight loss is more systemic. I hope this paints a really good picture for you guys on what the two, because they're very different. So, any questions on that before we move on to some pictures? So this next picture is of a hand, and I'm sure you guys have seen some old people with these symptoms on their hands before. So up here, and we'll talk about this more in the hand chapter, but these are your DIP joints, and these are your PIP joints. So in the middle of your finger are your PIPs, and these are your DIPs. When you start to see this bone on bone and you start to see this nodule or this node appear, In the DIP, it's a Heberden's node. Okay, this is hallmark. You see this stuff all the time. When it comes down to your PIP in the middle, this is a Bouchard's node. Okay, they look very similar, just where they are determines what the name of it is. So what a normal joint should look like would be like this, right? It has that perfect cartilage at the head of the bone. It's not rubbing bone on each other, but an osteoarthritic bone, you're going to see it with this wear and tear, the arthritis, or that's gone. So now you start to see this fusiform swelling of joints. So you see this more hallmarkly in, you can see it in osteoarthritis, but this is when you start getting down more to the base of the finger and in the thumb where you'll see this swelling. Okay. Now, I told you that you generally don't see swelling that much in OA. So in what type of arthritis do you think you see this fusiform swelling?
In rheumatoid arthritis?
Yep, rheumatoid arthritis. All right, guys. Good job. Good job. Any questions so far?
So this picture right here, is it just I don't know how to say it, osteoarthritis? It's both.
Osteoarthritis.
Osteoarthritis, it's both?
No, so the nodes, the Heberdens and the Bouchard's nodes are osteoarthritis.
And then the swelling is the RA.
The fusiform, yeah, I would characterize it under RA. Hang on, I was looking. I think Director Hurt emailed me back. She said, no, she read it, but she didn't email me back. All right, let's go to the next part. So diagnosing. So when you're starting to figure out which one is which, what do you got to look at? For OA, you look at a health history. What have you done all your life? That type of thing. What do your symptoms look like? They'll do a physical exam to see what the physical characteristics of this are. You can see osteoarthritis very well in an X-ray or an MRI if you need to. It's easy. It's very plain to see. But you have to rule out other arthritic conditions, and they do this through joint aspiration, and they do it through blood tests. Now, I'll talk more about that in just a second. With RA, they look at your extensive history. How long has this happened? They do a physical exam, blood test, and they also do imaging studies and all of that. I think it's on the next slide we're going to talk about. Maybe not. Where's that? With RA, one of the biggest diagnosing things is that blood test. And I thought I had the name of it written down, but I don't. Nonetheless, they look at RA markers that are in your blood, and that's one of the biggest ways that they diagnose it. And RA can look similar to some of these other arthritis conditions we're going to talk about that look systemic. So let's continue with this one, and then we'll get to those in just a minute. So what are we doing for treatment with OA? Pain management, try to improve their function, reduce potential for long-term disability, and their medical treatment can really vary on what joint it's in and how extensive is the damage. Do they need a replacement? Do they need a clean out surgery? Can they manage it with medication? Lots of different things that they look at with treatments. For RA, they will more than likely start them on an anti-inflammatory drug. NSAIDs, these are non-steroidal. These are things like Advil or things like that. Ibuprofen. Disease-modifying rheumatic drugs, or DMARDs is what you'll hear them called. Those are a certain type of medication that help block those RA. That's kind of like a pharmacy question. I just know they help with the blocking of those receptors, and it decreases your amount of flare-ups. And then also pain medication as well. Okay. Specific for OT intervention. Now, these are important. These are more for what I'm going to be testing you guys on. Are body mechanics are really important for OA, teaching them the right way to lift something. A lot of you, and I'm just as guilty, and I know this stuff, when you are a one trip to the car to bring in your groceries into the house, like Hercules, got to do it in one trip. It's really bad on your hands. Women like holding their purses with their hands and having that. What your hands are not meant to constantly bear weight like that. And that's really hard on your hands. So using larger weight bearing joints for carrying things, like if you're going to do the one trip thing, don't carry them all with your hands, put them up toward your elbow, or if you can, to your shoulder on some of those other types of shopping bags. That's much better on your body than trying to hold it all with your hands. Okay. Some lifestyle changes. It could be the patient is overweight and things like that. That makes you much higher risk for OA. So teaching something like that, teaching them adaptive equipment, a built up pen to sign their name, or built up spoon or something like that, because their hands have a lot of arthritis and they don't have the grip that they used to. That's all OT. And then environmental modifications as needed to help, especially with pain. Okay. Now for RA, we're going to talk a lot about exacerbation. Like, what makes these flare-ups happen? Is it changes in temperature? Is it range of motion? Or what is causing this flare-up? We talk about joint protection. If they damage their joint, like if they have RA and they're carrying in those groceries like that and putting all that weight on their hands, they're asking for an exacerbation. Like, they're doing way too much. If they're out running and putting all that weight on their knees and things, like constantly hitting it, that's asking for an exacerbation. We might even do some orthotics. Like, if a certain motion causes a joint to flare up, you might do an orthotic to block it and keep it in proper position. We're going to teach them pain and inflammation management. Never use heat, ever. And then adaptive equipment as well. Now, while the patient is in remission, you can do gentle progressive exercises. This is not them, I'm going to lift 30 pounds of dog food over my head and throw it 10 yards. This is very light stuff. This is maybe just some range of motion, maybe doing an arm bike, a light walk, something like that. This is not pushing them past their limits. Okay. The last thing you want to do is flare up a joint or flare up, get their RA flared up. Okay. You literally can damage their body. I
Can you
mean,
stay on this slide for a minute?
yeah, go ahead.
Thank you. Sorry, I didn't mean to
No, you're
interrupt.
fine. You go right ahead. Let me know when I'm good to go. You guys have any other questions so far? Because we're going to move into something past RA and OA.
Can you tell me again why? I mean, I know we went over it last semester, but why, like, you cannot at all put heat on RA?
Yeah, it causes exacerbations.
Okay.
Can you use
I have
heat
a
for
question
OA?
too.
Sure.
So with rheumatoid and osteoarthritis, when you're dealing with a patient, is that something that'll be like documented in their chart?
Oh yeah,
Or
it's a
is this
diagnosis.
something we should just like be able to identify when we see it?
Well, you're gonna know it as you see, and people will tell you like, oh my, you hear, especially right now with it being really cold, people will say, oh, Arthur's pissed off again. People say that kind of stuff all the time. But it'll be documented. It's their diagnosis.
Gotcha.
Yeah. Now you might notice it. For example, like you come in, somebody's just having a lot of shoulder pain and they really shouldn't after a while, and you start doing a little bit of tests, you start moving in a range of motion, or you hear like a grinding, you hear a uh, oh, what's it called? Like a popping or something like that. When you're working with somebody, you might be like, do you have arthritis? And they say no. But like, well, you might want to talk to your doctor and see if they want to look at something like that. You know, we don't diagnose, but you can see it plain as day.
Can you use heat on OA?
Yeah, you can, and it does feel good, but you shouldn't do a lot of heat. The rule of thumb with heat and ice with osteoarthritis is a 20-minute cycle. 20 minutes heat, 20 minutes ice. Now, most people are never going to put the ice back on it. Heat is just so temporary. I don't want you guys to think about like heat is a good thing to use if you're trying to get them to do like an exercise or something with you, want to loosen up the joint, but heat does not fix anything at all. It's very temporary.
So can you do ice with RA for pain management?
You shouldn't do any like crazy temperature changes.
Okay.
It's systemic. So if you throw your body into a systemic reaction, then automatically you're putting them at higher risk for an exacerbation. But heat is a really big no. Good questions. Is there
Since I'm the
anything
one
else?
who asked to stay on this slide, I'm good, but obviously can't speak for everybody. But I know I am good now.
Does anybody else need a minute? All right. I'm going to keep
Thank you
going.
again. That's a really good slide to have.
Oh, thank you. I didn't create it, but I'll take credit. All right. So fibromyalgia. Has anybody ever heard of fibro?
My mom has this. I actually emailed you during
Yeah.
break, if you remember.
So I'll tell you this. For in the medical world, fibromyalgia is kind of like a dirty word. Like some doctors don't even believe in fibromyalgia. I do. I just think that sometimes now it's like one of those terms we don't have and we'll talk about this in a second. We don't have like a standard, here's the test for fibromyalgia. It's literally looking at some symptoms and just kind of throwing a blanket term on it. I'll tell you about my experience with fibromyalgia here in a minute. So here's some symptoms of true fibromyalgia is pain, fatigue, some cognitive impairment. You'll see this thing, it's called brain fog or fibro fog, you'll hear it called. You don't see that with RA and with OA. The cognitive impairment stuff comes in with fibro. Again, for diagnosing this, there is no lab test. There is some criteria that the ACR has to try to diagnose that, and it's more or less looking at your history. Their diagnosing says that widespread pain for at least 3 months. It has to be on both sides of the body, and it has to be above and below the waist. Okay. You have to also have that fatigue with diagnosing fibro. And then there's trigger points. Okay. So you'll see with fibro, different types of trigger points are in there. That's why in the treatment side, you'll see like acupuncture and stuff. But you have to have tenderness in 11 of 18 of these specific trigger points. Now, I don't know which trigger points they are and all that kind of stuff for diagnosing, but they have to meet that criteria from the ACR to get diagnosed with fibro. That's like the standard of it. Now, again, some doctors they'll never diagnose this. They don't believe in it.
What I am like confused on when I was reading about that is like, is fibromyalgia, is it like, because on this one side it says physical and emotional trauma, is it like a mental thing, like a mind over matter type of situation?
It could be, and that's anybody's guess. There's people with much higher degrees and pay grades that do not agree that it's even a thing, that it can be explained by other things. But a true fibro patient, like when you meet them, if it is or isn't one way or the other, they have symptoms and their life is miserable. I mean, to be honest. I want to talk about treatment and I'll tell you about my personal experience with it. That just something that like a little nugget to keep with you if you run into this. So treatment here is pain management, symptom relief. Yeah, maybe do a little bit of exercise. There's not really flare-ups or anything like that. You might have some stuff that hurts more than others when you do exercises. So don't push them to where it hurts really bad or anything like that. They may do acupuncture, massage, that type of thing. Biofeedback. Again, that's above my pay grade. That's specializations and things. Meditation is something, and also dietary supplements. So my personal experience with this, my mom got diagnosed with fibromyalgia from a doctor up at WVU, and one of the first things that they prescribed to her was they wanted her to take Advil every day, and that's super hard on your stomach. And then also was meditation, and that's me. I was just like, what? Like meditation for treatment of a painful disease? That's crazy. So the other thing they said they wanted to try was a sleep study. So my mom, just knowing my mom, she's not gonna meditate. She's just not gonna do it. I know her. She's gonna think that's crap. She's not gonna buy it. But I talked her into doing a sleep study. They found out she had severe, like very severe sleep apnea. Once they got a CPAP, one of those machines, one of the breathing machines for her, and regulated her sleep, it all went away. Every bit of her pain. She's not been in pain for 2 years. She still has some osteoarthritis, like in her fingers and stuff, and her hands where she's tight. She's a nurse, has been for 30 years. But as far as like her whole body hurting and her like coming home in tears and having to take Advil just to take the edge off and thing, it all went away 100%. So again, she was actually diagnosed with fibromyalgia and that fixed it. So I can see where some doctors don't believe in it. Maybe it's overdiagnosed. Feel free to do a little bit more research on it and see what you want to believe one way or the other. I'm not going to sway you or even tell you if I believe it or not. That's just my personal experience. Okay.
I kind of wondered about that because my Aunt Teresa has that and she's always canceling our plans because her fibro's acting up.
Yeah.
So I always wondered about that.
Yeah, it's different. Do your own research. Okay. So here's some causes when somebody truly has fibro. It could be a genetic thing. They look at some infections earlier in life that may have caused it, and then physical and emotional trauma. These are things that they've identified as commonalities among fibro. Go back to what Felicia said about this whole idea of mind over matter. Maybe, especially because of the meditation thing. Again, there's just so much research out there that contradicts each other. Some are super in favor, some are very not in favor. The jury's out on this one. All right. Is there any other questions about fibro? Now, fibromyalgia is a diagnosable code. Like that's a thing. You might actually get a patient who's diagnosed with it, believes in it. Don't try to talk them out of it, but you might suggest something to just keep that in the back of your mind. Like, if you've been tested for sleep apnea, like maybe talk to your doctor about that. Okay.
Professor Gendler, I'm getting a phone call that I need to
Okay.
answer real quick.
Go ahead.
I'm just like confused on how physical and emotional trauma ties into it. I don't know if it's just like I just don't know. I'm confused on that part of it, I guess.
And honestly, I think half the medical community is, Felicia. I don't think anybody like, there are people that die hard that believe in it, and there's people that die hard don't. So best thing here to do is just look it up, see if you can find some additional stuff to sway you one way or the other, make your own decision. But if you treat a patient with it, just treat it as real and valid. I think even Director Hurt and I disagree a little bit on this. I think she's really like in favor of it. And I am to an extent. I just think it's kind of after my personal experience with it and my mom, I'm just a little bit more questionable. Okay.
So, because I mean, it's not new. I mean, I've heard of, fibromyalgia, like, I don't know how long exactly, but like, why isn't there a test for it?
There's not really it's because there's no physical marker really for it. There's some symptoms, but those symptoms fall under a bunch of different other diagnoses. I mean, there's hundreds of arthritic conditions. So fibro is not uncommon for people to be diagnosed with. It's just maybe overdiagnosed, maybe not, depending on who you ask. It's an interesting conversation for sure. All right. All right, let's go to our next one. So this one is called lupus. If you guys go to page, I think it's 634. Yeah, 634 in your book, bottom left-hand corner. So with lupus, it's another arthritic condition. You see painful and swollen joints. One hallmark here, the two hallmarks are extreme fever and fatigue and unexplained fever, and the butterfly-shaped rash. Okay, and that's what's on page 634 in your textbook. You guys can see what it looks like. It looks like a butterfly. That's telltale symptoms of lupus. They also are going to have photosensitivity, or they're going to be very sensitive to sunlight or bright lights. They may even have anemia or bad clotting factors and things like that. Now, this one's pretty easy to diagnose. There's blood tests for it, and there's a UA test or urinalysis test for it. Some causes here are they may have a genetic predisposition to it. They might have some environmental factors. Again, when you're talking about arthritis and these systemic arthritic things for sure, it's kind of like talking about a mental health disorder. They're not mental health disorders, don't hear me wrong, but remember when we talked about like the diagnosing of a mental health disorder, it's very difficult to do because you can't see into their mind and things like that. But finding the causes for these are difficult. There is a medication induced one that they can look at. I forget what kind of medication can be brought in by that, but there's one. I just don't remember what it is. But you'll see it as a risk factor on the bottle, like can induce lupus. Pretty crazy. All right.
Isn't lupus something that affects like more of your body than just your joints?
Yeah, we're gonna talk about that in just a second.
What is photosensitivity on the symptoms?
That's sensitivity to light, bright lights or sunlight or something like that. And it also can be like it can cause a flare up of lupus or make it feel worse. Like lupus sometimes is an unseen disease, and people will have like the handicap parking and stuff like that, and they get out and they look totally normal, like you would never know, but they may have lupus. And the reason is because they're trying to get in before the sunlight causes them to hurt more and stuff like that, so they don't stay out in the sun long. When I was in OTA school, a girl that I was in class with had lupus, and she talked a lot about it being like an unseen disease. So what Katie brought up is correct. Lupus does more than just affect joints. It can affect whole body systems. It can cause liver failure and kidney failure and diseases. It can affect a lot of things. Some other signs that you see are headache and confusion or memory loss. Raynaud's phenomenon, if you guys remember what that is.
Isn't that whenever like your hands are really sensitive to the changes in temperature? Like they can
Y-
get really cold and stiffen up.
Yeah, well, not only that, they look like they're a ghost finger or something. They're like super pale white. Um, and stuff like that, and they lose the color. Once they get one back up and get blood flow, it looks like it's a dead finger, more or less. If you
My
guys have
dad-
not, go ahead.
Let's say my dad has that, and his fingers are like permanently like gray.
Yeah, you can look up pictures, and it's pretty wild looking if you've never seen it. They also can have chest pain, swelling, and then it can affect several different body systems. Kidneys is a big one. So the treatment for lupus, medications, certain medications, alternative types of treatment. I don't really get into a lot of those, but just depends on what method you want to go through. And then an orthotic if they have arthritic changes. So if they start to see that joint swellings and things like that, and it's putting wear and tear damage on those joints, you might do an orthotic to help, keep good positioning of the joint and keep weight bearing off and all that stuff.
Can lupus cause osteoarthritis?
No, lupus by itself is just lupus. It can cause arthritic diseases. So if you have lupus and then you have like joint malformations, things like that, they're not gonna say, "Oh, that was OA." No, it was lupus that caused it. That would be like saying that osteoarthritis would be a symptom of lupus, but it's not. Lupus can look like it, but it caused it, not OA. OA is just wear and tear.
Okay.
Okay. All right. Any questions on lupus? Okay.
I have a question.
Yeah.
The butterfly type rash does that only present on the face or can it be anywhere?
It's on the face.
Okay.
To my knowledge, I've never heard of it anywhere else. And even I think our book talks about that butterfly shaped rash, and it goes right over your nose and onto your cheeks. And anytime I've ever seen lupus patients, that's what it looks like.
Is there anything that they can put on the rash? Like, does that hurt in itself?
I mean, I think it's like any other rash. Like it might be a little bit uncomfortable. They might do like a steroid type cream or something on it, but it's there. Like it's just their face kind of looks like what that is on page 634.
Are the symptoms like, are they like flare-ups, or is it just they have these symptoms the majority of the time?
Depends on the person. Some people like they have good days and bad days, like any other arthritic disease, but they don't characterize it as exacerbations and remissions like RA. But they might have good days and bad days, and then they have things that make it worse, and they have things that make it better. Good question. Anything else? You guys ask more questions on here than you do in class. All right, so the next one is gout, and I can talk to this personally because I have gout, and I'm here to tell you that it is the most. I always used to think my grandpa was crazy when he would talk about how bad his feet would hurt and things when he had gout. I'm here to tell you, like, it is intensely painful. It hurts so bad.
Can I add something to this?
Sure.
Okay, so I was at work a couple weeks ago, and one of our regular patients has gout, and he showed us his hands, and I guess he has like a very severe case of gout. And it was like he had like almost like bubbles underneath his skin, just like knots, just all over his hand. It looked horrifying. So I cannot
Yep.
imagine how painful it is because it looked terrible.
Oh, it's absolutely terrible. So what do you see with gout? You see this intense pain. And then you see swelling and redness. Typically you see it if you go to page 635 in your book, bottom right-hand corner, you typically see it in the joints of your big toe and your elbow. And you can see it in other joints, but those are the two big ones where you see gout. Okay. And it'll almost look like a bunion. If you know what a bunion looks like on the side of somebody's toe, that's what it'll look like. But that bunions are not gout. Okay. So it'll be very warm to the touch. It'll be very stiff. And the joint will look deformed, and it will deform the joint if it's not taken care of. You get these things called tophi. So tophi are those lumps that Caitlin was bringing up about it. And what that is they're called urate crystals. And this is from uric acid that's in your body that's built up. That's what causes gout is uric acid. It's an acid that your body naturally releases with certain things, things that you eat or drink. It's very diet based. There's a couple other random things that can cause gout. But anyway, but these urate crystals, you see them on page 635, they're very sharp. And it's just a ball of very sharp crystals stabbing into your joints. No wonder it hurts really, really bad. You're literally being stabbed. Literally. Just very tiny being stabbed. Okay. Some causes here is family history. If you have family members who have it, you're more likely to have it. Being a male or being overweight is also a high risk factor. Drinking a lot of alcohol, taking or eating foods that are rich in purines. This is red meat is a huge one. Steak, hamburgers that was what it caused it for me, was steak. We were on the keto diet and ate a lot of red meat, low carb stuff. And that food's really high in purines, and that caused it really, really bad. You can have an enzyme defect in your body, or organ transplants can cause it, or exposure to lead. Now, those are a lot less common. Most of the time, you're going to hear of gout being caused by diet and like health factors, being a male, being overweight. Like those are much more common.
So does eating those type of foods that causes it to begin, or does that just cause it to get worse?
It causes it to begin and have flare ups. So for me, I didn't have gout forever. And then last year, I just randomly got up one morning and I literally couldn't walk. Like it was so painful to do anything. So I went to the foot doctor and he was looking, he was like, I think you might have a flared up tendon, but I'm going to do a blood test just to make sure. He did the blood test and my uric acid levels were crazy high. And he was like, you have gout. Like it's no doubt whatsoever, which is kind of the next page about diagnosing. But it doesn't like it flares up. Like right now, I'm fine. Like my feet don't hurt now at all because I don't have a gout flare up. There's also some things, well, I'll talk about it here in a second, the treatment. So, diagnosing this again is that blood test for uric acid. You can see it on an x ray, but you can't really tell if it's osteoarthritis or something like that. Like at my age, it wasn't going to be osteoarthritis. It should have been, it was definitely gout, but you can see it on an x ray. They might stick a needle into that joint and pull some of the fluid out to see if it's uric crystals. If it is, it's gout. They're going to look at family history, and they might use certain drugs. And if those drugs or vitamins help it get better, it's probably gout. So for me, what treatment looked like, sometimes they'll do a steroid injection into the joint, and that gives it very temporary relief to get rid of the inflammation, but it doesn't fix it. The best thing is dietary modification. So cherries, anything high in vitamin C is like a counteractor for uric acid in your body. So it helps to calm it down. So whenever I had my really bad gout flare up, and literally, I mean, when I tell you it's painful, like even to have it sitting or have my feet propped up in the recliner was painful. Like everything hurt. So whenever I did it, I downed, like you can get 100% pure cherry juice at Kroger, and it comes in like a Gatorade looking bottle, and it's 100% no additives, no anything. It's just ground cherries. And I drank that. I ate a bag of cherries. I ate oranges. I mean, I probably overdosed on vitamin C, and I also gave myself like terrible stomach problems. It can give you like explosive diarrhea. So I overdid it. But it got rid of my gout. Like the next day I could tell that it was much better, and then the following day was better, and then it didn't fix it overnight, but it got better within a couple days. So now I really watch it with red meat. Like if I'm gonna eat, a hamburger at lunch, then we come home and we have a steak or something. Like I'm gonna make sure I have some cherries or something like that, or eat an orange, drink a lot of water, that type of thing. They can give you medication that keeps it away. I didn't want that medication. But they can give it to you to keep those uric acid levels low. Lifestyle changes, like losing weight is a big one. And then also education on what you can and can't eat, what you should and shouldn't do. All right.
Do you have like a quote unquote like is it like, oh, you get a flare up every week or oh, you get a flare up every month or something like that?
No, of all the art, and I again speak to this one very personal because I know it. I haven't had a flare up in quite a while because I really watch the amount of red meat and things that I eat. Once you identify that flare up, if you can find what makes it better and manage it that way, then it's a lot better.
Do you think it's possible if you you cut out those things that would make it flare up, and if you were to change your lifestyles that way, that you could never have another flare up?
Yeah, I mean, so far I haven't since I changed the way I was eating and doing things. Yeah, I haven't had any.
Does eating a lot of like seafood, like fish and stuff like that, will that cause gout flare-ups?
I don't think so. It's any food that is high in those purines. I'll just quick Google search will tell me. I just remember when I identified mine as that red meat, I still eat it, but I don't like to eat very much of it. And if I do, I eat something like cherries. So any organ meats, so like liver, things like that, those are high in purines. Any red meat, beef, um, herring, that type of fish. Apparently, chicken is also high. I've never heard of that. I remember dairy products is one. Um, Meat and dairy in general, and then sugary drinks are also high in purines. Okay. But you don't have to know all of that. Just know that foods high in purines cause it. Okay. All right, guys. So we're going to go ahead and take a break. Let's take a 10-minute break. Come back at 11:40. Don't log off the meeting. Just turn off your microphone and turn off your camera so that way we don't have to wait for everybody to get back on. I'm going to start back at 11:40 and I'm not going to stop the recording. So anything you guys say or whatever to each other, it will be recorded. Just know. Okay. So 11:40, meet me back here. See you in a few. All right, guys. Is everybody back? Maybe. All right. So, like I said, I'm going to post this lecture too, so that way you guys have it and can refer back to it since this is not traditional. But you guys can skip over that 10-minute break because it was recording the entire time that we're done. I don't like to break it up. I think that's silly. So it'll just still be one video. So let's talk about some medications that they use for treatments for arthritis. So they may use corticosteroids. This could be an oral, it could be topical, or it could be an injection type of steroid to help with the inflammation caused by whatever arthritis that they're dealing with. OTC, what does OTC mean?
Over the counter.
Over the counter.
Yep. Over the counter. So this is like an over the counter rub that you might get. These are like Bengay or Icy Hot or something like that they might use. You may be prescribed an opioid if it is too far. Again, that is not what you want to do because they're extremely addictive, but they might if it comes to a point where they just can't deal without it. Those DMARDs that we talked about earlier, they might prescribe certain antidepressants. Again, some of these, that's kind of above my pay grade of why. I know that they might use some antidepressants to help with sleep regulation, and a good restful sleep helps with arthritic pain. So antidepressants are commonly prescribed too for fibromyalgia. So again, that's a little bit past like why they might do that other than the sleep. I know that's a reason. Um, Maybe a low dose seizure medication. This is to help to release or limit the way that the brain releases chemicals that read pain or pain reactors. That's why they give that low dose seizure. Anti-malarial is like a systemic thing. They give it for to keep the body from attacking itself more or less in some of these arthritic diseases. Same thing with immunosuppressant drugs. It's just trying to keep the immune system from attacking the body. And then drugs that affect uric acid for the gout. Now, these drugs can affect OT treatment a little bit depending on some of the side effects that come along with them. Um, Basically, if you're having a patient, this is just a good rule of thumb. If you're having a patient who has this random symptom after they started taking a medication, or they say that they started having something after they started taking something, look into the side effects of medications and then maybe report it to the OT or the doctor if you say, hey, I know they've been taking this, but I've noticed this symptom. They've been complaining about this. It is a side effect of that medicine, and then let the doctor know they're having that side effect. Don't ever pull a patient off of a medication. Um, that's never okay. But if you notice something, say something. Okay?
So with the RA where you're not supposed to apply heat, could they use something like icy hot, or is that still counting as your heat that you're not supposed to apply?
Sydney, I don't know the answer to that. I was thinking about that actually as I was saying it. I don't think so because that would be an extreme temperature like a heat and then ice and all that. And I hate how it feels. My body is very sensitive to it. And you want to stay away from anything they might be sensitive to with RA, like that changes the way that they feel or even anything with temperature. I would probably not. But I don't know if that's a specific contraindication. I don't know that. Okay. I like y'all's clinical reasoning there with this stuff. You guys are coming up with really good questions. The home environment is giving you guys brain juice or something. All right, so let's talk about some surgical treatments of arthritis. Okay, you have an arthrodesis. This is where they fuse the joints together, so you lose range of motion, but you have decreased pain and increased stability. You'll see this sometimes in the ankle, in the wrist, the thumb, and the fingers. Okay. So they're just fusing the joint together. And arthroplasty, same as it is in every other thing that we've talked about, it's a joint replacement. You'll see this in the hips, knees, shoulder, ankles, wrist, elbow, or the MCP joints of your fingers. It is the same as it always is, replacement. Okay. And osteotomy. Now, this is only good for osteoarthritis, for the degenerative joint disease or the wear and tear type of arthritis, like we've talked about. This is where the bony defects are corrected. They take in and cut the bone and reposition. There might be a curvature or something that needs to be corrected, but nonetheless, they're cutting away a little bit and repositioning bones to help with the arthritis. We got two more. I'll go back to that in just a second if you guys need it. You have a resection. This is removal of all or part of a bone. So this would be going in and like cutting away those, if the bone is super sharp and has those bony spurs and stuff from arthritis, they'll cut that out and try to make it smooth again. And the synovectomy, this is with rheumatoid arthritis. This is where they go in and that disease synovium that's holding that synovial fluid in the joint we talked about, they take that part of it out. And this helps to decrease pain and swelling in the joints. You guys need me to go back to the first slide so you guys have it?
Yes, please.
Okay. So arthrodesis is joint fusion. Arthroplasty is joint replacement. Osteotomy, they use it for osteoarthritis, and this is where they cut away and position bones a little differently to help them flow better. All right. Everybody good on this slide? All right. Here's the slide. Let me know when you guys are ready with this one.
So they could do the joint replacement with OA2, or is that OA1 just specific to this? I don't know if that's making sense. Or is OA only specific to the one treatment? I don't know if that's
I don't know what you mean.
so like on that one side where they had the joint replacement.
Yeah.
That can be done with OA.
Yeah.
Or OA, okay.
Most of the time it's done with OA. So joint replacements, like think about it logically. Like how many times do you say, well, I have bad knees, I'm going to get a knee replacement. That's what that is. Is everybody good with this slide? All right, I'm going to move on then. So what are some of the psychosocial impacts and safety concerns with arthritis? So how do you think arthritis can affect a client's psychosocial well-being? April, what do you think? I haven't heard a lot from you today. What is, how can arthritis affect somebody's psychosocial well-being?
I feel like the pain, like the constant and like being uncomfortable and being in pain can really affect them in that aspect. I feel like the symptoms and like all.
Okay. For sure. I mean, it limits your life, right? Like you said, if they're living in pain and have pain a lot, they're not going to want to go out and go bowling or go on a hike or
Right.
anything like that. So it really limits what they're going to do. They're going to protect those joints a lot and try to keep them from flaring up. Very good. So how could OT help address, I mean, just that one aspect of psychosocial impact? Emily, how can OT address some of these psychosocial impacts?
Honestly, I'm entirely sure. I'm trying to think.
Okay, somebody want to chime in and help?
Can they work on like pain management skills?
Yeah, for sure. But think about it on the psychosocial stuff. So, like, we just gave the example that they can't go bowling. Like, maybe they were somebody who liked to bowl a lot, went out with their friends and bowled, and now they can't because of whatever arthritis that they're dealing with. What are some ways that we can, change it to make it more accessible for them?
This might be like a reach, and I don't know if it would even work, and I might just be thinking in a kid mindset, but I think maybe like the Wii, for example, like you can do bowling on the Wii and not have to go anywhere.
Okay, sure. If you need to downgrade it that far, I mean, you could change the way that somebody bowls. They could learn to hold the ball with their full hand instead of putting their fingers through the holes. They could learn to use that ramp thing that they have at bowling alleys to push it down. They could just go and be part of it. They could be a bowling coach. There's so many different things that they could do and maybe not do that exact activity or just adapt the way the activity is done. That's what OT does with arthritis. You're not going to heal it. Okay. You're not going to, you can help decrease exacerbations and educate them all you want to. Their arthritis is going to be there. Right. So you have to be able to teach your clients, is there a new way to do this? Or how can you participate and be a part of it? Maybe not do the full thing, that type of thing. Because if they completely pull out of something that they really love, that has a huge impact on their social life. Right? All right. The last part of this is, why do you think we tell our patients to forget no pain, no gain, especially with arthritis? So that whole saying of no pain, no gain that we hear a lot, that's a lie. Pain is a receptor from your brain saying, listen, stop. You're damaging the joint with arthritis. Why should we tell them to stop, and what should we teach them instead?
If they keep pushing to the point where it's painful, they're only going to be damaging it instead of listening and dialing it back. We could teach them whenever it is starts to get painful to try to find easier ways to do things to where it's not as damaging and it's not as painful for them to do what they were trying to get done.
Right. Or you as the clinician, you find a different way for them to do that. I'm no expert in bowling by any stretch, but I will learn whatever I need to about it. So walk me through the steps of it. Maybe we can come up with something together, like partner with them in that process, right? But you said it exactly right, Katie. Like, when it starts to hurt, stop. That's the basic rule of thumb. If it hurts, don't do it. If you push to the point of pain, you're only hurting yourself. Very good. So let's talk about some other OT interventions. In general, these go for all of them. Our goal here, what we're going to try to do, is decrease pain, improve their function. We might do an environmental or a lifestyle modification, depending on the person and the situation, and decrease the risk of deformity or disability. Okay, those are the 4 things that you guys need to remember. Write them down or take a picture. Decrease pain, improve function, do an environmental or lifestyle modification, or decreasing the risk of deformity or disability. You guys got those 4 things?
I have decreased pain, improved function, and I didn't get the next 2.
They're on that slide right there. Environmental and lifestyle modifications and decreasing risk of deformity or disability. All right, are you good? We're going to talk about each one of these different ways that we can do it now. Stop me if you need more time because, again, I can't see your faces, so you have to unmute and tell me. The first one is client education. So what are we doing with here? Decreasing pain, improving function, environmental modifications, and decreasing risk of deformity or disability. Right there. It's on most of these slides as we go through. It's got those four listed at the top. What are we doing? How is it helping this? Okay. So some different ways, specific client education is maybe a home exercise program or using modalities, maybe using the heat when it's when you're allowed or using ice when it's allowed or whatever. You choose to use whatever is appropriate. Joint protection techniques. So what I told you earlier about moving the grocery bags up to more larger joints and weight bearing joints, that type of thing. Pain management and stress management or relaxation training. That might be a big part of it too. You might need to teach them how to. Now that's kind of gearing in that fibromyalgia, mind over matter type stuff, but relaxing and not being so stressed, it does help all types of arthritis. So teaching them that is very important. Okay. Oh, go ahead and pull out your textbook if you guys haven't. Go to page. Hang on. 640. So I think that this chapter does a really good job of giving you guys some visuals on some practical ways to help clients. We're going to start going through these different pictures. So figure 24-1, use larger movements of the body to accomplish everyday tasks to preserve smaller joints. So this woman, instead of using her hand to grab the knob, which is this motion is actually not that great for your hand. It puts weight on it when you start to make a fist and you grab something. So what she's got, if you look really close, she kind of has a loop-ish looking thing that goes on the edge of the knob, and she just kind of turns her hips to open up her drawers. I'm going to assume this woman has pretty bad arthritis in her hands. Okay. Another thing, if she was able to, would be to get the knobs for your drawers where you maybe could put your hand in behind and pull back, like the open knobs. That would be a good way. In the next picture, she's distributing the load over several joints. So instead of grabbing that casserole dish with both hands like this and squeezing it to lift something, she's grabbing it from the bottom and she's distributing that weight over her hands and forearms to move it instead of grabbing it. Now, these are little things. Like, you truly would never think of this kind of stuff when you're adapting. That's why I like these pictures, because I think it gives very practical ways for you to change them. These are lifestyle modifications. Figure 2413 on page 641. Instead of taking a sponge and wringing it out and squeezing it and all that, you can take and just squeeze it between both hands. Okay. That's another way of taking some load off of the joints. Okay. So that's just some education you guys can do with the client. Just teach them a new way of doing things. If their hands hurt really bad with arthritis, it's going to hurt them in everything they do. So nothing that you adapt is going to be wasted time if it makes it easier and decreases their pain. Are there any questions on this part? All right, guys. Cool. So the next part is adaptive equipment. Again, That's what we're doing here is we are decreasing pain, improving function, decreasing risk of deformity and environmental and lifestyle modifications. All are important. So some different things. If you guys look on page 643, now we have some other stuff that is in our lab. I'll show you when we get there, but there's different types of equipment to help them be independent, right? So that is a key holder. So it pinches at the end of your key. You can stick it in the door and use your whole wrist and forearm to turn the key rather than just your fingers. B, that's a jar key. It kind of helps, like you pull up on it, you can twist and it helps get the lid off. C, lever doorknobs instead of handled. Now this one is an adapter, like it goes over a regular handle doorknob and gives you that lever. So they don't have to twist their wrist or anything like that. And then D, showed you guys before, that is a button hook. But you can see there, she has RA. You see that swelling in her hands? That's pretty telltale of rheumatoid arthritis. So if you're also struggling with coming up with ways to teach somebody a new way to do something like adaptations and stuff, go to the next page on 644 and table 24.2 and then 24.3. So this is, the top one is arthritis in spine, hips, knees, and shoulders. And the bottom one is for grip and pinch, some more hand stuff. It just tells you common adaptations you can use, different types of equipment that you can use, super cool stuff. Gives you a list. I recommend for arthritis stuff, go ahead and print this page out and put it in your FizDiz books. It'll be a really good tool for practice. Okay. Now we got a little bit of questions I want to go through with you on adaptive equipment. So, as you're giving these clients a new piece of equipment and teaching them how to do it, what are the main goals here? So we've got maintaining or increasing function and independence. That kind of goes without saying. What, or without overstressing the joints or the other body structures, and then what kinds of adaptive equipment might be needed. You have to ask yourself these questions. So am I giving them this piece of equipment to maintain or increase their function? If yes, good. If you're giving it to them to teach them learned helplessness, excuse me, that's not good. An example would be if they can reach over and tie their shoes, I don't care if they get out of breath or if it's difficult, if they're able to do it and not have a piece of equipment, don't give them elastic shoelaces. Don't give them a sock aid. Like, don't give them a long-handled shoehorn. Don't give them these things. That only makes them reliant on a piece of equipment. And the main goal here is independence without equipment. Now, I don't shy away from using it if I need to, but don't overly use it. Okay. The next question is, without overstressing the joints or other body structures, are you, when you add this piece of equipment, are you putting wear and tear on another joint? Or are you just pushing the problem down the road? Or is it actually solving something? If it's solving something, then move on to the last one. Okay, what type of equipment actually do they need? Okay, so now you've accomplished, you're increasing their independence, you're not overstressing the body or the joints. What piece of equipment am I going to recommend for this patient? And you should ask yourself that question really for any piece of adaptive equipment that you give a patient. And I mean, there are thousands. If you guys remember from the modalities lecture or class, I showed you guys that big book that you can order out of. You can go online and research stuff. I mean, there are hundreds of thousands of pieces of adaptive equipment. And if you say, hey, I need an adapted cell phone holder for a patient, just Google it and find the one that best suits your needs. I promise you there's 1,000 out there. Or you can be super smart, invent your own piece of adaptive equipment and never work again. Just sell it. Okay. Are there any questions on adaptive equipment? All right, cool. So Now, I'm going to very briefly talk about what an orthotic is, because that's actually what our lecture is on Thursday. If you guys go to page 645, there's some common orthotics that we give out for people with arthritis, but there's different finger splints, different joint blockers, some that we just don't want them to bend their fingers or whatever in a certain way, so it blocks that. That's a lot of those on the top on 645. There's resting hand splints, radial bar cock-up splints, and I'm going to teach you about what all those are on Thursday. So don't stress about this too much. But I want to mention with arthritis because we do use them. So anyway, but we'll talk a lot more about orthotics. I just wanted to kind of introduce what an orthotic is. We can custom them, we can order them, lots of different things. We're actually going to make an orthotic in class on Tuesday next week when we're in Charleston. That's the main reason we go to Charleston, is I like to teach that all together. Okay. All right, so edema management and modalities. So go to page 646 in your book. Main thing here, decreasing pain, improving function. Again, these are all hallmarks. You're doing this with these, but it looks a little different. You might use edema gloves. You might use a little bit of that retrograde massage that I taught you guys last semester. You might use like a resting hand orthotic or something like that. Maybe if it's soft and not hard, just kind of depends. But really you want to keep it with edema elevated, right? And you want to use that massage to try to get that edema out. That's pretty much edema in a nutshell. So you can control the swelling by doing a few things and increase function. First one is a lifestyle modification. It might be necessary to prevent edema. I like going back to that grocery example. Like if you have all that done, how many of you, when you've had your hands and you like carried in these huge amount of groceries, you look at your hands, you have the marks all over your hands, your hand is kind of swollen for a second. Now, if you have arthritis in those joints, that swelling is not just going to go away like it does with you and I. Like it's going to stay there for a while and their hands are going to hurt. Okay. You can use certain thermal and physical agents like the heat and ice. You could use that fluidotherapy that we talked about, but again, not on all. Make sure it's indicated for whichever type you're treating. Some modalities can be for home use, like that paraffin wax for osteoarthritis. Again, it's not going to hurt osteoarthritis. It'll make it feel better. Think about it logically. Why do you think? So what does osteoarthritis look like? Nobody knows.
It's bone on bone.
It looks like bone on bone, right? Like that cartilage that's on the head of the bones, that's wearing away. That's the wear and tear arthritis, right? So why do you think heat? What does heat do? Think back to our modalities chapter. Jordan, what does heat do?
It causes inflammation.
Okay, so yeah, it can, yes. But basically, go ahead and mute yourself. So it increases blood flow to an area, right? If there's an injury, the inflammation stays. If there's not an injury there, the inflammation can go away. But nonetheless, it brings blood flow to the area. That's why we use heat. That's why it feels good, right? So when you do that with osteoarthritis, you've increased this fluid going to the joint. Well, that's the reason that osteoarthritis exists, because that fluid is gone and then the cartilage wore away, right? So if you increase fluid to that area, of course it's going to make the osteoarthritis feel better, but it's just temporary. The fluid goes away. So it's a very temporary relief, and it doesn't fix anything. Okay. You can use it, but just know that it does not heal or fix anything that you're dealing with. Got me? So yeah, you could use that paraffin wax and stuff like if they have bad arthritis in their hands. It's going to feel really good for about 30 minutes and then it's going to be gone. Okay. All right. We're almost done. I'm gonna let you guys take a break, then we're gonna come back and we're gonna look at some worksheet stuff. Okay. So the next part would be therapeutic exercises or activities. The main thing here is decreasing pain, improving function. You might do some light resistive exercise, like very, very light. The next slide talks a little bit more about it, like graded progressive exercises. Start out very low and work your way up. If pain starts, stop. You've overdone it. Okay. If your patient's coming in the next day of therapy and said, man, my shoulders are killing me, I didn't sleep last night, you way overdid it with the patient. You might give them a home exercise program or a home activity program. Maybe land-based, maybe aquatic exercises if you want. If you have that opportunity, water is amazing for arthritis. It makes it feel good. So get in the water if you have the opportunity to. And then engagement in real or virtual leisure activities. It honestly just depends. What is the patient? Are they extremely limited? It kind of goes back to that bowling thing. I like the example that Felicia gave of the Wii bowling. Like they might not be able to go fully bowling yet. They might not be comfortable, but getting a little bit of enjoyment and leisure out of doing maybe Wii bowling. Absolutely. So our last slide here is about occupations. So when you think about arthritis, think about every way that this is affected. I talked to you about lupus and parking closer to the grocery store, osteoarthritis and bowling, rheumatoid arthritis. If they have a flare up, it affects everything. You can go through this list by yourself and think about like, how does it address ADLs, IDLs, health management, leisure, all of these different areas of occupation. What is arthritis affecting and how is it different for each one of these diseases? For sexual activity in ADLs, there's a really good chapter in your book. I forget what chapter it is, but it gives like adapted positions, it gives adapted techniques and things that you can help educate the patient on. Know your limits, like we talked about last semester, but that's definitely something you guys can address. And it's common because a lot of people stop having sexual activity because of arthritis, because it's painful, but maybe teaching them a different position or something like that, giving them a handout, talking to them about it, giving actual education or showing them some education is extremely important with something like that. Increases their quality of life. So. All right, guys, here's your knowledge assessment for today. A couple of these I'll accept more than one answer, but I only want one answer for each one of these. So the way I want this set up, I want to make sure everybody's hearing me. So set it up like normal, but when you do your answers, put like, if you think bone spurs go with osteoarthritis, you'll put 1D, 2A, or whatever it might be, whatever your answers are. I want the number and one letter beside of it, and that's it. Okay? Number, letter. That's it.
Can you like take mine out? I already did mine and I submitted it already, and I did it like I numbered them like with bullet points, and I put like bone spurs and I put like the letter of what I thought it was.
That's fine. Did you put the number with it?
Well, I used bullet points. I put bone spurs and then I put up under it like whatever I thought it was and put the letter. But I did put bone spurs, like, or botcher dog. Well, I don't know.
If I need you to redo it, I'll email you.
Okay, thank you.
Yep. All right, guys, I'm going to stop the recording.